Ma'am, we are discussing about the pharmacoinvasive approach in India. So, ma'am, before that, can I ask you what the STEMI burden you see in India and the western part of the country where you are practicing?
See, STEMI burden overall in Indian scenario or worldwide, it is about less than 1/3 of patients who present to us with acute coronary syndromes. May it be unstable angina or non-ST elevation myocardial infarction, but it's about 30% of all the cases have ST elevation myocardial infarction.
And what the time you see, ma'am? I mean, we have seen in the CREATE registry published from India,
Yes.
where the first medical contact from the onset of symptoms was almost 300 minutes. So 5 hours, that's a pretty long time. So how do you see, is it improved nowadays?
No, I think unless we have tertiary centers, more and more tertiary centers, and we have reached to the remote areas or the remote villages of our country, it is not possible to reduce the time from door to balloon or to achieve the ideal goal of 90 minutes from the symptom onset or door to balloon time. It is not possible to reach in India to have that time frame.
Right. So
so it is always delayed. Usually the patients present to us within 3 to 4 hours of the onsets of symptoms. So that the golden 90 minutes have already gone.
For doing the primary PCI, which is recommended.
Usually it's a delayed presentation. That is a big problem. Because millions of people do not have access to the tertiary centers. There are not many well equipped catheterization laboratories, the trained staff and the skilled interventional cardiologists who can take up the patient in the middle of the night also for primary angioplasty. And also financial constraints. That's also a big problem in India.
Right. So that's why, ma'am, all the guidelines talks about the pharmacoinvasive approach, where it's difficult to conduct the primary PCI within first 90 to 120 minutes of FMC. The patient should be thrombolized first and followed by referred for the PCI. What's your comment on that?
Yes, of course. In Indian settings, I think that is the way we go, pharmacoinvasive therapy, because currently available thrombolytic agents have excellent patency rate of infarct related artery, and also thrombin specificity, which will reduce the risk of complications of major bleedings, etc. And so it's very important to achieve the patency of the infarct related artery to salvage the myocardium. So it is always better to thrombolize these patients who are far away from the tertiary centers to get access to the angiography and primary angioplasty, and then we can shift them once they are stabilized, and then we can shift them to the tertiary centers and get the angiography and followed by angioplasty done in 3 to 24 hours after the pharmacological thrombolysis. And that is how we have seen the reduction of complications post STEMI, because as we know, in 1 to 3 hours of time we have a lot of complications after ST elevation myocardial infarction in terms of ventricular tachycardia, ventricular fibrillation, sudden cardiac deaths, if the the patency of the infarct related artery is not achieved at the earlier time. So that is very important to in the sense to achieve the thrombolysis and get the artery flowing, as we say. So and then take them up for the catheterization laboratory. It really helps us.
Right. So regarding thrombolysis, ma'am, we see now we have after first, now second generation, third generation thrombolytic agents. But still we see in India the maximum usage are for streptokinase. What's your comment on that, and what should be preferred?
Of course, streptokinase, of course, the earlier thrombolytic agent what we had, and we have been using it for quite some time now. The importance is, we have to offer our patients the newer thrombolytic agents, that is tenecteplase, because it has got a better profile of ease of giving, administration, and you can also administer this drug pre-hospital thrombolysis also can be done with tenecteplase with very fewer side effects. And secondly, streptokinase drug, of course, the only thing is that it is a little cheaper. That's the only, the financial constraints are the only things. But definitely with a better drug, better profile, and better patency rates are much better with tenecteplase, ease of administration, and secondly antigenicity is not there with tenecteplase, as we know. So it's definitely important to have that agent, and we should always offer our patients the newer thrombolytic agent, the third generation thrombolytic agents, to for a better profile.
After it's a life-saving drug. So
yes, it is a life-saving drug, and believe me, it really makes a lot of difference, and ease for the physicians also, because the complications of streptokinase, the hypotension, the reactions and allergic reactions are much more seen with streptokinase, and obviously they are not there with tenecteplase. So that is also definitely, many a times we have to stop streptokinase and restart it up. So you have already wasted 1 or 2 hours in just giving a thrombolytic agent, whereas in 5 minutes you just push, give the bolus of the injection, and then we have better results obviously with tenecteplase, no doubt about it.
Right. Thank you, ma'am. Thank you for your insight. So can I ask you just to give a concluding remarks on your topic?
So to conclude, in Indian settings, definitely when it is difficult to get all the patients for primary angioplasty in ST elevation myocardial infarctions, pharmacoinvasive therapy is a way to go to salvage the myocardium, to achieve patency of the infarct related artery, and that definitely we can do with pharmacoinvasive therapy.
Thank you very much, ma'am, for joining us the show.
Welcome.
Thank you. See, STEMI burden overall in Indian scenario or worldwide, it is about less than 1/3 of patients who present to to us with acute coronary